Welcome to The Explainer. Today, we're taking a completely fresh look at the biological blueprint of breast cancer risk. When we hear the words breast cancer, it is so easy to just get lost in a sea of statistics, headlines, and anxieties. But what if we looked at it differently, like a giant puzzle or a complex, multivariable equation? By unpacking the data and looking at the specific variables, from the unchangeable biology we're born with to the environments we live in, we can turn all that anxiety into solid, empowering knowledge. So grab your mental notebook because we are going to decode this risk equation together.
This breakdown brilliantly illustrates exactly why we need this explainer. Globally, breast cancer is the most frequently diagnosed malignancy in females. But where's that risk actually coming from? Well, about 50% of breast cancers are linked to known factors, things like reproductive history. But then only about 10% are tied to family history and genetics, meaning there's this massive 40% slice of the pie that is still driven by other demographic, lifestyle, and environmental variables. And those are the exact modifiers we're going to explore right now.
Okay, let's dive into this. Here's our roadmap. We'll start with demographics, move into body composition, explore hormones and reproduction, parse out genetics, and finish up with lifestyle.
Section 1. Demographics, the unchangeable baselines.
So the very first thing to understand is that risk is not static. It totally shifts over time. If we look at data from the SEER database tracking the probability of a female developing breast cancer in the US, you can see how it steadily climbs. From birth to age 49, the probability sits at 2.1%. Moving to your 50s, it ticks up to 2.4%. And by your 60s, it jumps to 3.5%. Basically, age is one of the absolute strongest modifiers we have. As we get older, that baseline risk just naturally goes up.
Now, if you compound all those age brackets from birth to death, you hit this absolutely critical baseline number, 12.9%. Put simply, the lifetime probability of a female developing breast cancer in the United States is roughly 1 in 8. That 1 in 8 is the overarching baseline we're modifying as we add in all these other factors.
But of course, that baseline doesn't apply to everyone equally. There's a stark reality here when we look at race and ethnicity. White females have the highest overall incidence of breast cancer, but you absolutely have to look at the mortality column. Black females have 5% fewer breast cancer cases overall, yet they face a staggering 44% greater mortality rate. The data shows they more frequently present with regional or advanced disease, and they have higher rates of triple-negative breast cancers. It's a sobering reminder that demographics intricately modify not just the risk of getting the disease, but the actual risk of the outcomes.
Section 2. Body composition, density, and the BMI paradox.
Now, what's really interesting about this is the complete paradox when it comes to body mass index, or BMI. It's not just a simple higher BMI equals higher risk situation. Actually, scratch that. It entirely depends on menopausal status. For postmenopausal females, a higher BMI and perimenopausal weight gain are definitely associated with a higher risk. Why? Because fat tissue essentially acts like a factory, converting precursors into estrogen, which raises the body's overall estrogen levels. But looking at premenopausal females, an increased BMI is actually associated with a lower risk of breast cancer, especially in early adulthood. We don't fully understand the biological mechanism for this inverse relationship in younger females yet, but it really highlights just how dynamic the body's systems are.
Another critical physical trait is breast density. Let's define this strictly in abstract, clinical terms for a second. Breast density is basically a ratio. It's the relative amount of glandular and connective tissue, which we call parenchyma, compared to the amount of adipose, or fat tissue, in the breast. Females who have mammographically dense tissue making up 75% or more of the breast have a higher breast cancer risk compared to those with less dense tissue. And while this is mostly an inherited trait, it can actually be influenced by hormones and even diet.
The physical associations don't stop there either. There are two other surprising physical traits that act as risk multipliers: height and bone density. Females taller than 69 inches, so about 5'9", are roughly 20% more likely to develop breast cancer. This is likely tied to nutritional exposures during childhood and puberty. And high bone mineral density? Also a known risk factor. Why is that? Well, bone is super sensitive to circulating estrogen. So having really dense bones acts as a long-term surrogate marker showing that the body has been exposed to high levels of estrogen over a lifetime.
Section 3. Hormones and reproduction, the blueprint of exposure.
Let's see how all this builds a timeline across a woman's life. The big theme here is the duration of hormonal exposure. Having an early age at menarche, specifically before age 13, increases risk. And on the flip side of the timeline, going through menopause later in life also increases risk. By starting earlier and ending later, the body is literally just extending the total number of years the breast tissue is exposed to circulating endogenous estrogen.
But what happens in the middle of that timeline is just as crucial. Look at the stark contrast regarding the age of a first full-term pregnancy. Having a first birth at age 20 is associated with a 20% lower cumulative risk of breast cancer. However, having a first birth at age 35 actually increases risk by 5% compared to females who never have children at all. Researchers think this happens because a full-term pregnancy causes full cellular differentiation in the breast gland, which protects it. If that first birth is delayed, breast cells are subjected to years of proliferative stimulation, meaning those older cells might be far more prone to damage. Outside of that reproductive timeline, we also have to consider the raw chemical messengers floating in the bloodstream. Higher endogenous estrogen levels are a direct risk association. But so is elevated testosterone, which preclinical data suggests might have dual effects on mammary tumor development. Higher insulin resistance, also linked to higher incidence. And externally, menopausal hormone therapy that specifically combines estrogen plus progestin has been shown to increase risk. Just keep in mind, we're framing these as complex associations that interact directly with our baseline demographics.
Section 4. Genetics. Parsing family history.
So I want you to ask yourself right now, does family history mean certainty? It is super common to assume that if it's in your family, it's an unavoidable fate. But the math tells a much more nuanced story.
Let's break down the actual multipliers here. The risk doesn't just flip on like a light switch because of a relative. It scales based on who and when. Having one first-degree relative, like a mother or sister, with breast cancer increases your baseline risk almost twofold. Have two affected first-degree relatives? That's a threefold increase. But notice this age factor. If a first-degree relative was diagnosed before the age of 30, that alone is a threefold risk increase. It's the number of relatives and their age of diagnosis that really dictate the multiplier in our equation.
But here's a number that completely surprises people: 6%. The absolutely crucial point is that only about 6% of all breast cancers are directly attributable to inherited pathogenic variants, like those much talked about BRCA1 or BRCA2 mutations. While family history certainly modifies your risk, the vast majority of breast cancers are not the result of a single, highly penetrant inherited gene mutation.
Section 5. Lifestyle. The environmental overlays.
Okay, we've built out our biological blueprint with demographics, body composition, hormonal timelines, and genetics. Now let's overlay the external lifestyle factors. These external modifiers have very clear associations with increased risk in the data. First up, alcohol consumption is a known breast cancer risk factor. Second, cigarette smoking. And the data is clear here. Even in females who don't drink alcohol, a smoking history modestly increases risk all on its own. Finally, exposure to therapeutic ionizing radiation to the chest at a young age, specifically that prepubescent window between 10 and 14 years old, like you might see in treatments for childhood lymphomas, creates a lasting vulnerability and increased risk later in life.
We have just navigated a massive amount of data today. From the unchangeable baselines of our age and demographics, to the complex paradoxes of BMI, through the lifelong timeline of hormonal exposure and the precise multipliers of genetics, right up to the lifestyle choices we make every single day. So I'll leave you with this. Knowing this complex blueprint, how much of your own risk equation can you actively influence? Understanding these factors is absolutely not about fear. It's about clarity. It's the first critical step toward having informed, objective conversations with your healthcare provider about screening and prevention. Keep questioning, keep learning, and thank you so much for joining me to decode the data.